So a pleasant day, dear doctors, and welcome to this Physiology Blitz. And for this brief but high-yield session, we will be talking about the must-know pearls about acid-base physiology. Now, in the recent board exams, the following references have been used. Now, for this module, we'll be utilizing BRS physiology. We'll be using Guyton and Hall textbook of medical physiology and some tables from Byrne and Levy physiology. So for this acid-base module, we'll be utilizing these three. Now, let's begin with the concept of acid-base physiology, which is actually a precursor to renal physiology. You should not study these two topics separately. Renal physiology and acid-base physiology should always be studied together. In most circulating handouts, it's only placed under one section. But if you go to the textbook, they are two different chapters. Okay, now let's talk about the pH, which is roughly in the middle of 7. Okay, this would be a neutral pH. Anything above that would be considered alkali, and anything below that will be acidic. As the numbers get lower and lower, okay, and closer to 1, that means it becomes strongly acidic. And usually, the concepts of pH are given as cases, okay, not computations, but rather as cases. And they're not going to tell you whether this is acidosis or alkalosis, but you have to interpret, okay? Now, in the concept of acid-base physiology, everything begins with the idea of acid production. Now, there are basically two types of acids which you have to be familiar with when it comes to human physiology. The first is the volatile acid. The second is the non-volatile acid. So again, what are the two, okay, what are the two, okay, acids produced? So we have volatile acid, then we have the non-volatile or the non-volatile acids. Now, let's talk about the volatile acids first. Now, the most important volatile acid that you have to bring with you to the boards is going to be carbon dioxide. I think in basic biology, we are taught that we inhale oxygen and we expel carbon dioxide. Now, from a human physiology perspective, it's actually more complex than that. Carbon dioxide is actually produced from the aerobic metabolism of cells. Now, can anyone tell me what is the product of aerobic glycolysis? What is the product of aerobic glycolysis? Okay, so we have two types of glycolysis. We have aerobic, then we have anaerobic glycolysis. Aerobic glycolysis, okay, aerobic glycolysis yields pyruvate. While anaerobic glycolysis, what is the end product of anaerobic glycolysis? Okay, the anaerobic glycolysis will yield lactate or lactic acid. Okay, now one of the products of aerobic metabolism in general is going to be carbon dioxide. Now, it's very important to remember that there is a reaction here. I hope everyone sees this reaction. So let me just box out this very, very important reaction. And I want all eyes to be here on this reaction, okay? Now, I want everyone to listen to this very closely, okay? So here, everything begins with carbon dioxide. Okay, carbon dioxide is here. Carbon dioxide will combine with water. Now, pause and analyze. What is the product of carbon dioxide and water? Can you type in the answer? What is the product when carbon dioxide combines with water? What is this? This is what we call the famous carbonic acid. Okay, again, this is carbonic acid. Okay, please take note of that. Okay, again, please take note of that. Carbonic acid. Okay, so I hope everyone got that. So carbonic acid is formed. Now, always remember carbonic acid is a weak acid. A carbonic acid is a weak acid. And something else happens, which everyone must memorize. And that is this carbonic acid will dissociate. It will dissociate into hydrogen and bicarbonate. Now, the most important product here is going to be the bicarbonate. So I want everyone to remember this. Now, what is the name of the enzyme that catalyzes this reaction? What is the name of the enzyme that catalyzes this reaction? It is the famous carbonic anhydrase. Now, question, this was asked very recently in the boards. What is the cofactor of carbonic anhydrase? What is the cofactor that is needed by carbonic anhydrase? Very good. It is zinc. Okay. The cofactor, okay, is carbonic anhydrase. Please take note of this. Okay, again, please take note of this, carbonic anhydrase. So I hope this is clear. So there's a dissociation of carbonic acid, okay, a dissociation of carbonic acid, okay, into hydrogen and bicarbonate. This bicarbonate plays a very important role, most especially inside the red blood cell, because this will buffer, okay, the hydrogen. Okay, now here, this is the famous enzyme, which is actually present in most cells, which even includes the eyes, okay, the kidneys, okay, the lungs. So this catalyzes the reversible reaction between carbon dioxide and water. This is carbonic anhydrase. Do not take the exam if you are not familiar with this reaction and you have not memorized it by heart. Now, question. What is the name of the drug? Okay, what is the name of the drug that inhibits carbonic anhydrase? What is the prototype, yung pinakasikat na carbonic anhydrase inhibitor? Okay, so this is acetazolamide. Now, memorize by heart that acetazolamide is used to treat mountain sickness, okay, or what we call high altitude sickness. High altitude sickness. Mountain sickness or high altitude sickness. It is also used to treat, okay, glaucoma, okay, and it also decreases the CSF production. So it's used in cases where there is elevated intracranial pressure. But tip, always remember, if you're asked which is the best drug to decrease intracranial pressure, it is mannitol, not acetazolamide. Okay, mannitol is more effective for increased intracranial pressure. Okay, so always remember that. Now, the second type of acid that is produced is what we call a non-volatile acid. Now, in the textbook, a non-volatile acid is also known as a fixed acid. Okay, and one of the most important acids under the non-volatile, dalawa yan. One is sulfuric acid, second is phosphoric acid. So I want everyone to memorize the non-volatile acids as sulfuric acid and phosphoric acid. Now, please take note, sulfuric acid is actually the breakdown product of protein catabolism, one of the breakdown products of protein catabolism, while phosphoric acid is one of the breakdown products of phospholipid catabolism. Now, usually there's about 40 to 60 millimoles of non-volatile acid which are produced per day. So please refer to your study guide and take note of this. Okay, so what is the most important volatile acid which you should bring with you when it comes to human physiology? What is that volatile acid? Okay, let's see if you're still with me. Okay, very good. It's carbon dioxide. And what are now the two non-volatile acids which you have to remember when it comes to human physiology? Non-volatile acids. Ano yung dalawa? Okay, very good. It's sulfuric acid and it's phosphoric acid. Okay, so please take note of that. God forbid you answer muriatic acid, huh? Please, please. Okay, now I want you to remember that when we talk about non-volatile acids, there are other fixed non-volatile acids that can be produced either as a result of a disease condition, or they may even be ingested. Now, we have three you have to be familiar with. One is the keto acids. Second, lactic acid. Three is salicylic acid. Now, let's try to dig this in detail. When would you expect keto acids to be produced? In what conditions? In what conditions would you expect keto acids to be produced? Okay, one, diabetes mellitus. Okay, which is more common for ketoacidosis? Is it diabetes mellitus type 1 or diabetes mellitus type 2? Which is more commonly associated with ketoacidosis? It's usually diabetes type 1. Okay, diabetes type 1 is more associated with ketoacidosis. Okay, so I want you to remember that. Now, I want you to remember by heart that there are three ketone bodies. Okay, what are these three ketone bodies? We have hydroxy, okay, butyric acid. Okay, can anyone fill in the blanks? What are the three ketone bodies? We have aceto, acetone, a hydroxy, butyric acid. Okay, we have acetoacetone. Okay, then we have acetoacetic acid. Okay, now in some textbooks, acetone is just mentioned as acetoacetone. Okay, so this is acetoacetic acid. These are your three ketone bodies. Okay, now in what conditions would you encounter lactic acid production? Okay, one, you have the exercising muscle. Okay, so in what conditions would you encounter lactic acid production? You have sepsis, okay, which is associated with tissue hypoperfusion. Okay, you can also encounter lactic acid in an exercising muscle, a septic patient, particularly when there's hypotension or tissue hypoperfusion. Lactic acidosis is also associated with ingestion of what oral hypoglycemic agent? What oral hypoglycemic agent is associated with lactic acidosis? Okay, it's metformin. Okay, and in what glycogen storage disease is lactic acidosis associated? In what glycogen storage disease is lactic acid, okay, associated with, or lactic acidosis? So we have glycogen storage disease type 1, which we call von Jerk's disease, okay? Salicylic acid poisoning or ingestion is of course associated with ingestion of aspirin, okay? Ingestion of aspirin, whether it's accidental or intentional, okay? So please take note of that. Okay, great, you're still with me. So please scan the slide and stretch while you can. Now, what about the term buffer? What is a buffer? A buffer is a chemical or a substance which prevents a change in the pH. Okay, whenever hydrogen ions are added or removed from a solution. Now, always remember that buffers can either be intracellular or extracellular buffers. They are most effective within a pH of 1.0, okay, of the pK of that specific buffer. So take note of this, the buffer. So the buffer will prevent a change in the pH. They're there to balance the pH. Now, I mentioned that a buffer can either be extracellular or intracellular. Now, for the extracellular buffers, I want you to remember these two, bicarbonate and phosphate. Now, between these two, which do you think is the most important? Okay, which is the most important? Okay, the most important here is the bicarbonate. Okay, we're not saying phosphate is not important. Hi, let me clarify that. Okay, bicarbonate, textbook wise, and of course, physiology wise, is the most important. Okay, it is the most important. So, for examination purposes, since we're heading to a series of quizzes and long exams, I want you to remember both bicarbonate and phosphate, they are extracellular buffers, okay? Now, here is a summary from the 3 textbooks I mentioned to you earlier. The major extracellular buffer is bicarbonate. We talked about the reaction with carbon dioxide and water and the role of carbonic anhydrase. So how is bicarbonate formed? It is produced from the combination of carbon dioxide and water. Again, how is bicarbonate formed? It is produced from the combination of carbon dioxide and water. Phosphate is considered a minor extracellular buffer. Okay. So please take note of that. So minor buffer, say phosphate. Now, phosphate, although it is a minor buffer, it is the most important urinary buffer. Urinary, not blood buffer. Okay. And phosphate is actually excreted, and it is excreted as a hydrogen. Okay. And it is going to be in the form of hydrogen phosphoric acid. Okay, so please take note of this. And this is what your physiology books refer to as a titratable acid. Okay, a titratable acid. Now, what about the intracellular buffers? They are usually comprised of the organic phosphates. Okay, now these are the organic phosphates which serve as an intracellular buffer: adenosine monophosphate, diphosphate, and triphosphate. Now, what is the organelle which produces ATP? Come on, a no-brainer question. What is the organelle that produces ATP? What is the organelle that produces ATP? What is the famous cellular organelle that produces ATP? It is the mitochondria. Okay, now let me jump off with a clinical question. What is the mitochondrial disorder that presents with stroke, seizures, and lactic acidosis? And this is usually seen in pediatrics. Stroke, lactic acidosis, okay, the presentation: stroke, lactic acidosis, okay, and seizures. Okay, this is the famous condition known as MELAS. Okay, this is the famous condition known as MELAS. This came out in the pathology exam. Okay, next, there's another mitochondrial disorder, okay, which presents with muscle weakness. Okay, and it presents with the ragged red fibers, okay, on muscle biopsy. What is this disease? Ragged red fibers using Gomori trichrome stain. What is this mitochondrial disorder? Okay, this is known as MRF. Okay, this is known as MRF. Okay, and there's another disease that presents with the ragged red fibers. This is inclusion body myositis. Okay, just take note of that. This also presents with the ragged red fibers. Okay, now going back, another intracellular buffer is 2,3-diphosphoglycerate, or 2,3-DPG. Okay, and take note that hemoglobin is also a major intracellular buffer. Now, something worth bringing to the exam is the comparison between deoxyhemoglobin and oxyhemoglobin. Always remember, deoxyhemoglobin is a better buffer than oxyhemoglobin. So please take note of this. Okay. Next, this is a must know. Okay, everyone has to know this. Where does reabsorption of filtered bicarbonate occur? Okay, where does it occur? It occurs in the proximal tubule. Now, this is the expected question. What diuretic acts on the proximal tubule? What specific diuretic or group of diuretics acts on the proximal tubule? Okay, let's see your answers. What diuretic acts on the proximal tubules? Ano? Which of the diuretics? We have a handful of diuretics, okay? Which, okay, would act on the proximal tubule? It's the carbonic anhydrase inhibitors, okay? Which of course is exemplified by acetazolamide, okay? Now, question, where does majority of sodium, where is it reabsorbed? What part of the tubules? Majority of sodium is absorbed where? Is it the proximal tubules, the loop of Henle, or the distal collecting tubules? Where? Where is most sodium absorbed? Okay, it is in the proximal tubules. Okay, so please remember that. Now, I want you to take note of this. Key features of reabsorption of bicarbonate that is filtered. So again, both hydrogen and bicarbonate are produced in the proximal tubules. And this is, of course, formed from the cells, okay, from carbon dioxide and water. Now, both will combine carbon dioxide and water to form carbonic acid. And we already mentioned this earlier, that this reaction is catalyzed by carbonic anhydrase. Okay, now let me share this figure. So this is that reaction. This is the side of the lumen. This is the side of the cell, and this is the blood. Okay, so here is the hydrogen plus the bicarbonate. This is now carbonic acid. Okay, so here is the carbonic anhydrase. So in the side of the lumen, here's the carbon dioxide plus water. Okay, carbon dioxide plus water from the lumen to the cell. Carbon dioxide and water combines, it forms carbonic acid. This is catalyzed by carbonic anhydrase. Carbonic acid will dissociate to hydrogen and bicarbonate. Bicarbonate is filtered and reabsorbed. Okay, and please don't forget that as bicarbonate leaves the RBC, what comes in? Fill in the blanks. As bicarbonate leaves the RBC, what will now shift going inside? Sino yung papalit ni bicarbonate? Okay, what important ion will now shift? Okay, it is going to be chloride. And what do we call this famous physiologic process? Okay, what do we call this? Yung pagpalit ng bicarbonate and chloride. Okay, as the name implies, this is the chloride shift. Okay, this is the chloride shift. Now, I want to mention the importance of PCO2. Okay, always remember that increases in PCO2 result in increased rates of bicarbonate reabsorption. Okay, so again, increased PCO2 would result to increase bicarb reabsorption. Okay, and this is the basis for the compensation for respiratory acidosis. Okay, this mechanism is the basis for the renal compensation of respiratory acidosis. Now, Another concept to remember is if there are decreases in PCO2. So this is actually basically the opposite. If there are decreases in PCO2, there's also decreased rates of bicarbonate reabsorption. This is now the basis for the renal compensation in respiratory alkalosis. So always remember, if the primary acid-base disorder is going to be respiratory, what is the compensation? Is it renal or is it respiratory? Fill in the blanks. If the primary acid-base disorder is respiratory, what is the compensation? Again, if the primary acid-base disorder is respiratory, what is the compensation? Is it respiratory or is it renal/metabolic? It should be what? What is the compensation? Okay, it should be renal or metabolic. Okay, always remember that. Okay, now with regards to ECF volume, okay, always remember there is volume expansion. ECF volume expansion results in decreased reabsorption of bicarbonate. ECF volume contraction results in increased bicarbonate reabsorption. This is what we call contraction alkalosis. Now, question, what is the most abundant cation in the ECF? Basics, be? What is the most abundant cation in the ECF? It is, of course, sodium. Okay, sodium is the most abundant cation in the ECF. Now, what about in the ICF? What is the most abundant cation in the ICF? What is the most abundant cation in the ICF? Okay, very good. Tama, ha? It is potassium. Okay, it is potassium. So please take note of that. So here, the most abundant ions in the different compartments. In the ECF, that's sodium and chloride, bicarbonate, and calcium. Most abundant cation being sodium. In the ICF, the most abundant cation is potassium. And don't forget, phosphate and magnesium are also very abundant in the ICF. Okay, so please remember that. Now, I'm sharing with you this table, okay, very, very important table as to the substances which are used for the measurement of body fluids. Now, tip, it is this body fluid volume measurement. Total body water, which we abbreviate as TBW. We usually use antipyrine. For the ECF, we utilize inulin. Now, can anyone give me the other physiologic process which is measured by inulin? What else does inulin measure aside from extracellular fluid volume? What does inulin measure? Mga anak, okay, very good. It is the glomerular filtration rate, or the GFR. Very good. Now, intracellular fluid, okay, is calculated as the total body water minus the extracellular fluid volume. So you need to compute for the TBW first and the ECF, and then you can compute for the intracellular fluid. Now, plasma volume is measured by Evans blue dye. Okay, now what if I tell you it's renal plasma flow? What is utilized to measure renal plasma flow, or some would use the term renal blood flow? what substance is used for this? Okay, it is para amino hippuric acid. Okay, para amino hippuric acid. Okay, so that's basically the only things I want you to know from this high yield table. Now, what do we call this equation? Okay, the pH is equal to the pKa plus the log of the conjugate base and acid concentration. Okay, what do we call this famous equation? Rest assured you will not compute for this. You just have to identify the name. Okay, this is the famous Henderson-Hasselbalch equation. Okay, Henderson-Hasselbalch equation. Very good. Okay, now for your blood gas normals, just utilize these values. Don't be surprised if from one physiology book to another, one laboratory to another, maybe there might be a slight variation of the range, but it's more or less the same. PO2 of 90, a PCO2 of 35 to 45, and a bicarbonate of 22 to 26. Okay, so please refer to your study guide. Now let's mention the concept of an anion gap. Okay, now this is the formula that you have to memorize. Yes, you need to memorize the formula for an anion gap. So what laboratory values is required for you to compute for the anion gap? You need to know the sodium, you need to know the potassium, you need to know the chloride, and you need to know the bicarbonate. Okay, again, you need to know the sodium, the potassium, the chloride, and the bicarbonate. Now, what will most likely come out in the boards are the conditions that causes the wide anion gap. Okay, so what is this concept? The physiologic concept behind a serum anion gap that is increased. So the serum anion gap is increased if the concentration of an unmeasured anion is increased to replace bicarbonate. And the examples, take note, the examples of the acids, okay, or the unmeasured anions rather, are phosphate, lactate, hydroxybutyrate, and formate. Please jot this down. The four unmeasured anions, the four unmeasured anions, okay, which is increased to replace bicarbonate. So please take note of this. Okay. So don't forget these four unmeasured anions: phosphate, lactate, beta hydroxybutyrate, and formate. Okay. Now, lactic acidosis with a high anion gap. You have to memorize the causes. So number one, okay, must know is, of course, lactic acidosis. ketoacidosis. Now, in addition to the diabetic ketoacidosis or the DKA that we mentioned earlier, alcohol abuse can lead to ketoacidosis. Now, for the specific toxins, I just want you to emphasize on the following. You don't have to memorize all, okay? Uremia and aspirin, okay? Uremia and aspirin. So I want you to take note of that, okay? Uremia and aspirin, uremia and aspirin, methanol and lactic acid. Now, cyanide specifically blocks what complex of the electron transport chain? Cyanide. Okay, cyanide blocks complex 4, okay, which is of course cytochrome oxidase. Okay, cytochrome oxidase. It's complex 4. Now, metabolic acidosis with a normal anion gap occurs when, number one, there's administration of acid and loss of bicarbonate, such as when there is loose bowel movement or diarrhea. Okay, so loose bowel movement or diarrhea. So please take note of this. Now for metabolic acidosis, so these are the etiologies. Number one, rapid addition of a strong acid. A loss of bicarbonate, such as when there's gastrointestinal losses or renal losses. Okay, normal meat-containing diets, and rapid expansion of the ECF by utilizing, okay, bicarbonate-free solutions. Okay, so please refer to your study guides. Now, I just want to emphasize on this. This is a very high-yield table showing you more than what actually is found in Gaiton. Okay, so ketoacidosis, so there's accumulation of beta hydroxybutyric acid and acetoacetic acid, okay, because acetone is not an acid. Lactic acidosis, okay, this can be seen during hypoxia, chronic renal failure, okay, salicylate intoxication, methanol, so mud piles is here, ethylene glycol, diarrhea, and they now mention the renal tubular acidosis. So please take note of this. So just take note of the RTAs 1, 2, and 4, which is associated with significant metabolic acidosis. Then we have metabolic alkalosis. So the etiology would include, number one, loss of gastric secretions, the use of diuretics, okay, rapid correction of chronic hypercapnia. So be careful in patients with COPD, chronic lungers. You're not supposed to correct the hypercapnia too abruptly. Okay, when there's increased mineralocorticoid activity, so aldosterone tumors, hyperaldosteronism, when there's profound potassium depletion, and when there's milk alkali syndrome. Now, milk alkali syndrome occurs when you give antacids with what specific antibiotic? What specific antibiotic, okay, would cause milk alkali syndrome when you add this with antacids? Okay, it is tetracyclines. Okay, tetracyclines is milk alkali syndrome. Sulfonamides, the golden term for sulfonamides is Stevens-Johnson syndrome. Okay, so always remember that this is tetracycline. Tetracycline should not be given in patients with antacids because it causes milk alkali syndrome. So please take note of this. I want to share this very, very important screenshot. Okay, this is a screenshot from one of our textbooks. I find this very, very useful. So here, under metabolic alkalosis, of course, this is the vomiting. Then there's the hyperaldosteronism, which we mentioned earlier. And now they add the use of specific diuretics, particularly loop or thiazide diuretics. Okay, now please remember, loop diuretics, this is of course furosemide, classic furosemide, Lasix. Then of course you have your thiazides, which is the prototype is going to be your hydrochlorothiazide. Okay, so please add that to your memory bank. Okay, now I am precisely showing you this figure because this is where a discussion came in. This actually came out in medicine when they gave a case scenario of a patient with profuse vomiting and they were asking for what happens or what is the level of angiotensin and aldosterone in response to this profuse vomiting. The answer there is elevated levels of angiotensin 2 and elevated levels of aldosterone. This is because of volume contraction of the extracellular fluid. So please take note of this. Okay, and the increased aldosterone, this is the culprit for the hypokalemia. Okay, so always remember that. Okay, so I hope you got that. So this is a very, very important tool, okay, which showed how even a clinical subject like medicine was asking basic physiologic must-knows. Okay, so please take note of this. Again, please take note of this. Okay. We're almost done. Okay, we'll be done in a few minutes. Now here I want to share this slide also regarding respiratory acidosis. So opiates, okay, so morphine causes respiratory depression. Now question, what is the antidote for morphine toxicity, morphine or opioid toxicity? What is the antidote for morphine or opioid toxicity? I swear on my life, this is going to come out in your boards. Okay, this is of course naloxone, opiate antagonists, or they might use the term naltrexone. Okay, naloxone. Now, GBS or Guillain-Barré syndrome can cause respiratory failure. Amyotrophic lateral sclerosis can cause respiratory failure. Now it says here multiple sclerosis. I just have to justify that not all patients with MS will present with respiratory acidosis. This is only when the MS involves maybe the cervical cord and respiration is affected, or if the demyelination involves a part of the brain that controls respiration. Otherwise, respiratory acidosis would not be something prominent in MS. Okay, COPD, yes, of course, COPD. Okay, now question, what is the most common bacteria which is associated as a prodrome or as an antecedent infection for GBS? Most common bacteria which causes an antecedent infection, usually diarrhea. This is Campylobacter jejuni. Now, I want everyone to remember that H. pylori. Does anyone know the old name of H. pylori? It was actually called Campylobacter urase because it's urase producing. Okay, so please take note of that. So Campylobacter jejuni is usually the antecedent infection. Okay, so let's wrap up things with the last slides. So here, respiratory alkalosis, you see this in hypoxemia, psychiatric disorders like hysteria or hyperventilation syndrome. You have to remember the mechanism why there's numbness, there's tingling sensation around the lips, the fingertips when there is hysteria, and respiratory alkalosis is because hydrogen will now compete for calcium at the binding sites. And there's going to be a corresponding hypocalcemia, which would explain the numbness and tingling. Now, aspirin overdose is also associated with respiratory alkalosis and hypermetabolic states like anemia, hyperthyroidism, particularly thyrotoxicosis, as well as febrile states. Please take note of this, okay? So here in the screenshot from the table in the textbook, so respiratory they put there psychogenic, okay? They actually put here pulmonary emboli because in pulmonary embolism, what is the most common sign in pulmonary embolism? And what is the most common symptom in pulmonary embolism or PE? Now, the most common symptom in PE is sudden unexplained dyspnea. The most common sign in pulmonary embolism is tachypnea. The tachypnea, the increase in the respiratory rate, this is the one which causes the respiratory alkalosis. Okay, so let's end with this table. So I want you to refer to your study guide, and I want you guys to study this well. Look at what happens to the hydrogen in the bicarbonate and what is the respiratory or renal compensation as the case may apply. Okay, very, very important. Okay, so I'm going to give this as your reading assignment. And of course, here, what is the primary disturbance and what is the compensation? So just remember the rule of thumb in classic acid-base disorders, okay? Whatever the primary acid-base disturbance is, if it is metabolic, the compensation is respiratory. If the primary acid-base disturbance is respiratory, then the compensation would be metabolic, okay? So I want to end with that pearl, okay? Are there any questions?